on renal cell carcinoma.
Thank you. So talk about if you will compete with surgeons in treatment of renal cell cancer. I do hope to give you the right answer at the end of the lecture. We know that with the small renal masses, we can excise, ablate, or observe the small renal masses. What we know from literature is that compared to nephrospastic surgery, significantly increased local progression rate has been discovered for cryoablation, radiofrequency ablation. But however, at the end, no statistical differences were detected in the incidence of metastatic progression. It doesn't matter if we ablate, excise, or observe the lesion. We know that for small renal masses, we know that these masses grow up to 3 millimeters each year, but the only factor significantly associated with the development of metastatic disease is the tumor size. While growth rates vary considerably among all the reports, we know that only 1% of observed lesions in this meta-analysis from Chawla progressed to metastatic disease. So we can also observe this lesion. But we know that in 1997, so almost 20 years ago, the first renal cancer was ablated and then the tumor was resected, while 2 years later, RFA was used as the only treatment for renal cancer, and the case was published. We use, not me, in the medical literature, cryoablation starting from 1995. We know that alternating cycles of freezing and thawing, we can obtain a mechanical disruption of the cell membrane, and this will lead the cell to death. So with cryoablation, we know that we can fix, we can modeling the tumor, and we can obtain destruction of bigger lesion, very large, up to 4 or 5 centimeters in the kidney. But we know that major drawbacks in the literature coming out from the radiology, interventional radiology report, is the lack of biopsy-proven renal cell cancer compared to surgical data. Also, in case of active surveillance, we don't have the biopsy-proven renal cell cancer, what we see and what we follow with the CT scan. From PSUCA in 2013, we know that in 143 patients with T1A renal cell cancer, we obtain an estimated 5-year recurrence-free survival rate of 91.5%. And Whitson, also recently, in a cancer registry with more 7,000 nephron-sparing surgeries and more than 1,000 ablation, showed very similar 5-year disease-specific survival rate, more than 95% each. In the same paper from Whitson, we know that ablation was associated with a twofold greater risk of kidney cancer-related death than nephron-sparing surgery. Age, gender, marital status, and tumor size were also significantly associated with the outcome. Again, the DSS after 5 years was more than 95%, as I told you before. For those treated in 1998, so 20 years ago, a much stronger difference was observed in those undergoing surgery versus ablation. Not today, not starting from 2007, in which no difference between treatment arms were noted and registered. Also, there was an increasing use of cryoablation compared to the other kind of ablation for renal cell cancer. This is a very important meta-analysis in cardiovascular interventional radiology, in which the conclusions are that the thermal ablation of small renal masses produces similar oncologic outcomes compared to surgical nephrectomy, and is associated with a significantly lower overall complication rate and a significantly loss or reduction of the functional rate. So we need more randomized controlled trial in order to decide to treat also young patients with small lesion in the kidney. The effect was similar in this meta-analysis between the two treatment options, while the overall rate of complication was significantly higher in the surgical group of nephron-sparing surgery compared to the mini-invasive treatment. Major complication again was also higher in the surgical group compared to the mini-invasive technique, and obviously the need for retreatment of the lesion was higher in the group of ablation compared to the nephron-sparing surgery. again, and we all of us know very well this, that the decline of renal function in mini-invasive technique is minimum compared to what happened while performing a radical nephrectomy or also a tumor nephrectomy. Again, the year of publication and the size strictly influence the overall rate of complication, so it means that the larger the tumor and the more recent the publication, the more the risk ratio shifted in favor of thermal ablation. And this is what can we do now today in the third millennium. In this young patient, 60 years old, we started treating this patient in 2010, solitary kidney, several lesions growing up during the follow-up. We treat with more than 13 ablation in this kidney. And these are all the findings. Also, my friend Frank Olsi treated this patient with IFU for metastatic lesion in the pancreatic body of this patient. And we obtained in this hilar case, these are all the probe with cryoablation during this hilar lesion at this level with the service needle Ciba needle in order to perform a dissection of the perineal fat and protect the ureter while performing the ablation at this level. This is another, again, Thompson, in which the local recurrence-free survival was similar between the treatment surgical series analyzed and the more than 350 ablation, doesn't matter with the radiofrequency ablation of cryoablation. In this paper, the metastasis-free survival was significantly better after partial nephrectomy in cryoablation compared to radiofrequency ablation. And there was also a bias for which we have an overall survival better for the surgical group due to the fact that younger patients were enrolled in the group of the surgical group. Obviously, the surgical cohort, the comment to this paper are that the surgical cohort was biologically more aggressive due to the fact that in 80% of the cases there was biopsy-proven renal cell cancer, which was proven in 41% of patients ablated with radiofrequency and up to 60% of patients ablated with the cryotherapy. The patients in the surgery group were 10 years younger and less comorbid compared to the patient in the mini-invasive technique, and also the patient in the surgical group were monitored up to more than 5 years compared to the 2.9 and 1.4 respectively in the group of radiofrequency ablation and cryoablation. So this work underscores the idea that for a patient who are too frail or too comorbid to undergo surgery and for whom active surveillance is not recommended or ideal, tumor ablation is an acceptable alternative. They talk always about acceptable, but there is no definitive accord in order to treat also younger patient, 40, 50 years old, for a small region mass. Also, again, other cumulative, other data, United States population-based analysis of nephron-sparing surgery versus clear or thermal ablation, which more 8,000 cases, showed an almost twofold higher adjusted risk of kidney cancer death in the case of the group of the ablation, while in another series, they found out a tenfold increase of major complication with surgery and fivefold increase of local progression rate with ablation. We know that with mini-invasive technique, we will have higher local recurrence rate but fewer cases of complication, major or minimal complication. And again, in another report on U.S. national practice, with more 15,000 patients enrolled, there was no statistical difference in cancer-specific or overall survival between ablation and radical or partial nephrectomy. How to use, when to use radiofrequency ablation or cryoablation, they try to compare both technique with small renal masses, so with the size less than 3 centimeters, and they found no differences in terms of local recurrence rate, up to 3.2% in case of radiofrequency ablation and 2.8% in case of cryoablation. So the conclusion are the RFA cryoablation are more effective in the treatment of renal masses, measuring 3 centimeters or smaller, and major complications for each technique are infrequent. This is what we dream, usually a solitary kidney with multiple lesions, both on the posterior and the anterior side, solitary kidney. Usually the urologist sends us the solitary kidney, a small lesion discovered during the follow-up. We have to perform the dissection of the perineal space with the CO2 or room air, not obviously with saline when you're using radiofrequency ablation, and to treat this lesion. More complex case, solitary kidney with a mass lesion, no small because 4 centimeters in diameter in the central side of the in the sinus, or the renal sinus, and another one with endophytic growing pattern in the upper pole of the left renal kidney. So we decided to perform a cryoablation with 4 probes at this level. And 1 month before, we treated the lesion with radiofrequency ablation, the lesion in the upper pole. Before performing the cryoablation, the urologist gave us the opportunity to put a double J stent technique in the CT scan room. And we obtained, after 3 years of follow-up, these results with total shrinkage of both the lesion with no decrease in renal functions in this patient. And this is the last follow-up a couple of days ago in 2015. Gervais in 2005 showed us that we can be effective in 100% of the cases in case of smaller lesions smaller than 3 centimeters, and effective in 81% of the cases with lesion more than 3 centimeters in diameter. Zagoria shows that the size diameter could be 3.5 centimeters. We can be effective, but over 3.5 centimeters. The effectiveness is of 47% in this series. As opposed to RFA, cryoablation gives us the opportunity, the chance to treat lesion greater than 3 centimeters. And we know that we can treat central tumors because we know that radiofrequency has a higher recurrence rate in case of central lesion, with 67% of under treatment in case of central lesion compared to 96% of lesion non-central tumors. Why this? Because we can use cryoablation to safely and successfully treat central located tumors due to a limited thermal sink effect compared to radiofrequency ablation. And from animal studies, we know that there is a low risk of damaging the collecting system while using cryoablation compared to radiofrequency ablation. Young patients who refuse the surgical nephrectomy in case of chromophobe renal cancer, we put inside 4 cryoprobes at this level, and after 18 months of follow-up, these are the results with total shrinkage of the lesion. We have to be very competitive with surgeons also from a cost analysis because we have to convince the administration of our hospital that we are convenient also from an economical point of view. So if we compare microwave ablation, radiofrequency ablation, cryoablation, irreversible electroporation, we know that the cost mainly depends on the number of the probe that we use. Obviously, when you perform a radiofrequency ablation or microwave ablation, it's not so common to use more than 2 probes, maximum 1 probe or 2 probes. This is not what happened with cryoablation or reversible electroporation, so the cost mainly depend on the number of the probe that you use. But if you compare the open partial nephrectomy, robot-assisted partial nephrectomy, laparoscopic radiofrequency ablation, or computer-aided tomographic radiofrequency ablation, these are the numbers. So you have to check the administration of your hospital that in case of small renal masses, you can be competitive both from a clinical point of view and from an economical point of view. In this other paper, the predictors of total cost were surgical approach, the length of stay, and the operative room time. So this is very important for me. As oncologic and safety outcomes improve and become comparable in all nephron-sparing surgery compared to radiofrequency cryoablation and microwave ablation, cost of each procedure will start to play a stronger role in the clinical and healthcare policy setting. Again, the percutaneous approach in this paper was 2 to 2.7 times less costly than other options and resulted in cost saving of $3,000 up to $5,000 US. This is a very important paper in which they define the axial, the size of the tumor. We know, as I told you before, that the size of the lesion we will obtain different numbers in terms of tumor local control, and Ferragis also shows size greater than 4 centimeters to be significantly associated with tumor recurrence. This is again a renal cell cancer, solitary kidney, exophytic tumor, less than 3 centimeters. We can be and we have to be definitive in this treatment by performing the radiofrequency at this level with no signs of recurrence and the ghost of the lesion at this level. Microwave ablation in this paper, they put the medium size up to 4 centimeters, and they have the half of the patient with local recurrence rate, and they retreat the patient with technical success in 100% of the patients. So with microwave, we can treat also tumor bigger than 3 centimeters with a medium size of 4 centimeters. Cryoablation, as I told you before, we can treat lesion greater than 3 centimeters with a local recurrence rate of 2% in this series, with a tumor greater than or equal to 3 centimeters in a mean follow-up of 15 months. We can obtain this number due to the number of the cryoprobes that we can use while approaching this lesion, also because we can monitoring the ice ball during the ablation, and we can check the total covering of the tumor with safety margin while we are performing the cryoablation. In this case, I 8 cryoprobes in case of diffuse mass in order to obtain only at the bulking, not to be curative, only to obtain at the bulking in bilateral involvement of both the kidney, we can obtain 7 centimeters in necrosis. So we can suggest to use radiofrequency ablation, microwave ablation, if you don't have any problem with the money, with the cost, also cryoablation for lesion smaller than 3 centimeters, from 3 up to 5 centimeter cryoablation or more. The data in the literature support the use of preoperative embolization, like in this case, 80 years old patient with several comorbidities and previous basilioma. This is lesion. We perform an embolization with microsphere calibrated from 500 up to 700. We obtain the vascularization. This is a contrast media within the lesion, which we perform the approach always of the lesion under ultrasonographic guidance with freehand technique, but we check always with CT. You cannot perform this kind of procedure only with US. You have to check with CT scan during the procedure. And these are the results with the ablation. Obviously, this is an exophytic tumor, so the insulation of the perineal fat gives you the opportunity to obtain greater results compared to the endophytic lesion in the renal kidney. And these are the results in the follow-up with also a thrombus developing in the inferior vena cava and a blind fistula at this level, but with no fluid collection in the perirenal space. How can you can handle the bowel loops because you have to be worried not to damage the bowel wall with heat or also with freezing. So you can roll a patient, or you can perform the dissection in the perineal fat with CO2, also with dextrose in water, obviously when you are using the radiofrequency ablation, also with the room air, not only with the CO2. For the anterior upper pole, you have to perform, usually you can obtain an oblique approach to the lesion, but you can safely approach the lesion with a transhepatic approach. For the lesion in the upper pole, you have to be very, very careful. Also, when you perform ablation of the lesion in the subcapsular space in the 7th segment, you have to be very careful not to damage the adrenal gland. So you have to perform the procedures with strict cooperation with the anesthesiologist team. You have to perform aggressive blood pressure monitoring, and you have to block the patient with the alpha blockers or beta blockers in the week before, on the days before the procedure. For the medial lower pole, you have to be very careful not to damage the branch nerve coming out from the genitofemoral nerve or lateral femoral nerve. With a problem with a patient while treating him with the cryoablation was a recurrence in the iliopsoas muscle, and we had the damage of the lateral femoral nerve. So please always perform a dissection at this level with CO2. This is a cryoablation with two probe with a transhepatic approach. We routinely use the transhepatic approach in case of this lesion, also with cryo for adrenal gland or for ablation of kidney cancer at this level. This is how we monitor during the procedure with the invasive technique, with the anesthesiologist, the blood pressure in this patient. And another source of problem, complication, is the ureter. You have to perform all the things that you can do for protecting the ureter, performing dissection of the perineal space, leaving in place a double J stent. You can remove the double J stent the day before, the day after the procedure. Also leave in place in case of suspected lesion, suspected diffusion of heat or freezing at the level of the ureter in order to protect the ureter from subsequent stenosis due to the heat conduction. For cryoablation, remember always that the cryoprobe are fixed within the tumor, so you can pull him back or push toward in order not to freeze the no-target lesion. Lesion touching there is a renal sinus fat, as I told you before. There is Gervais show us that there is a local treatment failure of 20% of the cases in case of tumor adjacent to the renal sinus fat. For cryoablation, these do not occur in order to be very, very safely to treat the lesion in the central part of the kidney with low level of recurrence rate. Another factors is the growth pattern of the lesion, growth pattern endophytic versus exophytic. Endophytic is totally surrounded by renal parenchyma. In this case, the recurrence rate in this paper were of 15% in endophytic tumors compared to 4.3 in non-endophytic tumors. So in this case, you have to use all that you have in order to detect the endophytic tumors with contrast-enhanced ultrasonography, with fusion imaging, or administration of intravenous contrast media during the CT control. We know that microwave ablation is faster than radiofrequency ablation. In this paper, they compare microwave ablation with open radical nephrectomy, and although the overall survival after microwave was lower than after open radical nephrectomy, with 67.3% after microwave and 97.8% after radical nephrectomy, the RCC-related survival was comparable to radical nephrectomy. The microwave group, obviously, as the other source of ablation, had less surgical time, estimated blood loss, and postoperative hospitalization. And the total effectiveness was 98% in this Chinese paper. No major complication occurred. The hazard ratio for recurrence was higher for patients with multiple nodules, larger nodules, endophytic lesion that needed more ablation time. This is what usually happens also with other source of ablation. Microwave ablation, endophytic tumor, and approach at this level, a 1-year follow-up with no signs of recurrence at this level. In this other paper, they compare the microwave ablation with the cryoablation with no difference in local or metastatic recurrence between cryoablation and microwave in treating small renal masses. So the indication for treating renal cell cancer, we have to take a look to the age of the patient, to the life expectancy, laboratory parameters, disease extension, and patient compliance. We know from this data that I show you, renal ablation is an effective treatment with a low risk of complication in elderly patients, comorbidities, impaired renal function, multiple renal cell cancer, solitary kidney, previous partial nephrectomy, or in transplanted kidney tumor. Comorbidities, 8 years old male with previous lymphoma, renal cell cancer, one of the first patients that we treated in 2004 on 5, multi-pronged needle, posterior approach, and the media follow-up, the CT control after the ablation, and this is a shrinkage of the lesion in the year after in the follow-up of the patient. Solitary kidney with previous nephrospare surgery, so we have local recurrence also in case of nephrospare surgery. So you have to say to your surgeon so they can have also recurrence in nephrospare surgery. Consider that in nephrospare surgery, in 9% of the cases, the surgical margins are positive for tumor cells. And so we have to treat. We publish our experience in treating solitary kidney. So we come to the European Association of the Urology guidelines, the selected recommendation and treatment of localized renal cell carcinoma. Patients with small tumor and or significantly comorbidity who are unfit for surgery should be considered for an ablative approach. This is what the urologist means about ablative technique. So we can take this we can treat this kind of patient if they are unsuitable for surgery. Looking to the complication, we know that the anterior lesions are 5 times more likely to cause bowel complication than posterior lesions. Always take a look to the bowel loops. In case of urinary leak, you have to put a nephrostomy tube and then a double J, as I told you before, double J stent in order to protect the ureter. Bleeding is more common in cryoablation compared to radiofrequency ablation, and you can predict the efficacy and complication following percutaneous renal ablation by applying this renal nephrometry scoring system, which if you score 4.26, you will have a low complexity procedure, 7.9 moderate complexity, and 10 to 12 high complexity procedure. And in this paper, there is a local treatment failure in a patient with renal score of 7.6 versus 6.7, and major complication with a mean nephrometry score of 8.1 versus 6.8. So you can preview the complexity and also the complication of the procedure. In this other paper, they applied the modified renal nephrometry scoring system by moving the cutoff from 4 centimeters down to 3 centimeters. Now, the role of the pre-ablation biopsy. We have to perform at least 2 courses of biopsy with an 18 gauge or larger biopsy in different tumor regions, in performing the biopsy in the periphery, in the central side of the lesion, avoiding the necrotic area. And again, this consensus on the small renal biopsy, how, what, and when perform the biopsy, we know that we have to perform always the renal biopsy before the ablation. Always, biopsy has to perform it before tumor ablation in all the cases. So, the last 3 slides, can we compete with surgeons? Again, with this Psuka paper, in poor surgical candidates, RFA results in durable local control and low risk of recurrence in T1A renal cell carcinoma. Higher stage correlates with a decreased disease-free survival, patient selection based on tumor characteristics, comorbid disease, and life expectancy is of paramount importance. In another paper for Lewini, reported the comparable 5-year survival rates for radiofrequency ablation in comparison with partial nephrectomy in matched contemporaneous cohorts. So we can compete for small renal masses with surgeons. So do we still lack long-term oncologic efficacy data for radiofrequency ablation in a population with high comorbidities? The answer is no. Can we extend the indication for radiofrequency ablation to young, healthy patients who desire a minimally invasive treatment options? We need further prospective, ideally multi-institutional studies to pave the way for widespread use of radiofrequency ablation or cryoablation in case also of small renal masses. In the future, thanks to renal sampling and molecular profiling, more than half of the small renal masses, those with non-aggressive characteristics, so you have to perform always the biopsy, could be treated with radiofrequency ablation and not or included in an active surveillance program, sparing patients the inconvenience of surgery. Thank you for the attention.
Thank you very much. Thank you for being on time. Questions from the audience? You're mainly performing cryo, correct?
No.
Or
no.
RF?
Otherwise, the administration of my hospital will kill me. So We use cryoablation in case of central side tumor, larger than 3 centimeters. In exophytic tumors, we perform radiofrequency ablation. When the lesions are bigger than 3 up 4 centimeters, with the exophytic growth, we use also microwave ablation. So we use what we need for a specific case.
Okay. The surgeons, when we were doing open with cryo, because they were the first, they were doing cycles of thawing and freezing, and they complained about ice ball cracking, something that we do not see in percutaneous approach a lot.
No.
Do you think that has to do with the approach, with the open approach, or is something because it's close?
We are more gentle compared to surgeons in order to treat this kind of patient. I personally think that in the next couple of years, the young urologists will perform the thermal ablation of the small renal masses by themselves as the hepatologists in case of hepatocellular carcinoma, because the clinical data, the results by treating these small lesions are very, give you a lot of satisfaction.
Any questions? Thank you.